I'm excited to talk about detecting and addressing geriatric syndromes in people living with dementia. And I think I really have the special treat of being able to be the first speaker among this esteemed group of panelists today. I've had the chance to take a sneak peek at the other talks. And I think what's nice is I hope that I'm going to set us up with this sort of more overview, kind of from a clinic-based perspective of some of the topics and strategies that you're going to hear more about in more detail from the other speakers later today. My disclosures include a Geriatric Academic Career Award grant, that a GACA that I'm just in my last month of, from HRSA, that supported my development as a clinician educator, as well as a Center for Excellence in Alzheimer's Disease grant from the New York State Department of Health, and I have no other disclosures. So my objectives for our time this morning are that we understand the relevance of comprehensive geriatric assessment in people living with dementia, that we recognize and assess or learn to recognize and assess core geriatric syndromes in people living with dementia. I'm going to focus on polypharmacy, weight loss, and falls, and that we understand basic steps in management. And just to sort of give a lay of the land for the agenda for my time, I'm going to give some introduction and then start with a patient story, which you might have traditionally think of as a case. I'm trying to move to more person-centered language, so I'm calling it a patient story. And I know you're going to hear more about person-centered care from Dr. Mork later today. So we'll go through a patient story that will help us, I think, be able to contextualize and ground some of the other issues we'll discuss. And I'll talk a little bit about the conceptual framing of what we're doing in comprehensive geriatric assessment and what geriatric syndromes are. We'll dive a little bit into some specific tools and strategies for assessing and managing polypharmacy, weight loss, and falls, and then a little bit about how we operationalize this in the clinic on a health systems level, although I know that Dr. Geriatric and Ms. Quinn will go into much more detail about that later today, and then just a summary. I wanted to just start out as well to contextualize where I'm from. So here's a picture of one of the sites where I work. This one's actually in Yonkers. Our Center for the Aging Brain is a multidisciplinary cognitive assessment and treatment center. And so for any adult age 55 and older who gets referred with some kind of cognitive concern, they get a comprehensive geriatric assessment first, and then they go on to see a neuropsychologist, a neurologist, and social worker. And we have other team members that we involve with as needed, several community partnerships, and I'm really privileged to be part of this team. And so moving to the patient story. This is an 88-year-old woman with Spanish language preference and a history, and I apologize for the abbreviations. I had to do this for the sake of slides, but I'll translate a little bit to make sure we're all on the same page. High blood pressure, diabetes, arthritis, stroke, and legal blindness from macular degeneration, as well as a history of falls. And she's coming in for a follow-up visit with her daughter. And one of the main concerns that the daughter mentions is that they need more caregiver hours, more hours in which there's a paid caregiver in the home, specifically overnights, because of concerns of increasing depression and anxiety. The patient sometimes saying things like, "I'm not sure why I'm still alive," poor sleep, she's up at night frequently, and worsening of forgetfulness. She's forgetting her date of birth, forgetting where she lives, sometimes not recognizing family members, and really she can no longer use her phone on her own anymore. The patient's main concern is just neck and shoulder pain. That's what she says is bothering her. And just a little bit more background about her to kind of catch you up to where we are now. About 3 years ago, she had a stroke in the Dominican Republic where she was living. That's where she's from. And as a result of the stroke, she developed speech, vision, and memory problems, and so came to live with her family in New York City. At that point, was still independent with her activities of daily living. She was bathing, dressing, transferring on her own, all of that. Excuse me. And then 2 years ago, when she came to the clinic, it was noted that her memory was worsening. The PMIS, that you see there in the middle, that's an abbreviation for the picture-based memory impairment screen, which is a brief cognitive assessment that we like to use over here in the Bronx. It's based on the memory impairment screen, except it uses pictures instead of words. And this iteration was developed by my mentor, Joe Verghese. And so it's not culture and literacy bias, which is one of the reasons we really like to use it in our diverse population. And so her scores on the PMIS, which again, it's a test, it's a brief test, less than 5 minutes, that primarily checks recall. Her scores were not normal, in the not normal range 2 years ago, and then really over time have gotten worse and worse, from 5 to 2 to 0 points out of 8. And her clock drawing test, she was unable to do that. So that was 2 years ago. And so she got a trial of donepezil, but it had to be stopped because of side effects. She also developed falls, incontinence, and was forgetting, again, more of her identifying information. And then a year prior to this visit, she had some further decline, started having delusions, thinking that people were coming into her home, especially at night. Apathy. She was losing interest in things she previously used to enjoy doing, and again, with poor sleep, and was developing constipation and abdominal pain. And that's really when her vision also got worse a year ago, and she became legally blind. And again, I'm going into some detail about this because I hope you'll keep some of these details in mind about this patient's story as we talk through later today. A little bit more about her social history. I mentioned she's from the Dominican Republic. She had no formal education, and she had worked in a clothing factory, and she had never been a smoker. In terms of her current living situation, she lives alone in a second-floor apartment that does have an elevator. She has 3 children, and she has 9 hours per day of a paid personal care or home attendant. And one of her daughters is the most involved of her children, but that daughter has another full-time job working overnights as a home attendant. And then she's getting called frequently about her own mother, who's up at night or having other difficulties during the day. So I want to pause here, and I want to make this a little bit interactive, hopefully to get us awake and thinking this morning. I would love for you to pause and think to yourself, and really feel free to drop something in the chat. What else you might want to know about this patient, what you might be concerned about for this patient, what you might want to recommend for this patient, even at this point. Would love to, and I'll read some things out from the chat if I see anything. We'll take a moment to see if anyone has any thoughts. What does she like to do? What are her normal activities? Someone asks. See if anyone else has any other thoughts that you're wondering about this patient in order to help her. What are her medications? And we're definitely going to get to that. What services does she have now in addition to the home attendant? What protective factors? Does she have access to a day program? I knew that many people in this audience have a lot of facility with a lot of these topics already, and I hope to learn from some of you. I'm going to take some of these ideas as well. Social life, social connection. Great. So we're going to talk more about some of these things, and I'll keep moving. Thanks so much for your thoughts, those who jumped in. And so keeping this patient in mind, we're going to talk a little bit about conceptual framing of what we're doing when we're meeting a person with a cognitive concern and trying to really unpack and understand the whole picture of what's going on with them. So we're doing a comprehensive geriatric assessment, and I like definitions. So I want to mention start with a definition here. And this one is a little old, from 2016, but it's thought of as a multidimensional, interdisciplinary diagnostic process designed to determine the medical, psychological, and functional capabilities of frail, elderly individuals. I apologize for elderly. Again, this is a little outdated. We would say older adults now, in order to develop a coordinated and integrated plan for treatment and long-term follow-up. And so it's a lot to do. Obviously, it's a lot to do in often a short amount of clinical time, but we're really trying to cover a lot of bases. And I have appreciated in reflecting about comprehensive geriatric assessment, which is what I do in the clinic with my patients, that the 4 M's or 5 M's of age-friendly care, and when we think about this, we're thinking about how do we actualize and implement comprehensive geriatric assessment kind of on a much broader scale, on a systems level, on a community level, on a population level even. So to me, it's how do we take this beautiful, complex, rich, and nuanced clinical evaluation we do with one patient and be able to mobilize that and disseminate that among many, many patients. So it's very, very exciting that we have this framework now, thinking about this going forward. And when we do comprehensive geriatric assessment in someone with cognitive impairment or dementia, why is this especially important? And I know some of this may be very germane to many of you. One of the reasons it's really important to do a comprehensive assessment is to address geriatric syndromes, these clinical conditions which develop when an individual experiences accumulated impairments in multiple systems that compromise their compensatory ability. What's really been interesting too is to look in the geriatrics medical literature that some of the most useful and informative and robust research in geriatric syndromes and comprehensive geriatric assessment, in addition, of course, to David Rubin's work, I have to credit him, I think, which was sort of the origin of all of this, but is in the geriatric oncology community, where we're really thinking about identifying patients who will or won't benefit from oncologic treatments. And we need to really understand who the patient is before we can make those treatment decisions. And so, and you can see the source I've quoted there, the ASCO, American Society of Clinical Oncology educational book. So it's great that oncologists are thinking about this. So what is a geriatric syndrome? And I have this figure here from an article in the Journal of the American Geriatric Society in 2007 by Sharon Inouye and colleagues. And what I think is so interesting and so much fun really about it clinically and from an intellectual perspective, I guess, in terms of what is unique to geriatrics is when we're treating geriatric syndromes, it's really distinct from treating some other types of medical pathology, in that a geriatric syndrome, right, is going to be a combination of symptoms, phenomena that doesn't necessarily have one specific cause. And we know that different geriatric syndromes, you can see a short list of some of them there, have multiple shared risk factors. And so it's a little bit less of a one-to-one relationship. It's a little bit more complex. And we know that when individuals have multiple geriatric syndromes, they can interact with each other, and each of them increases the likelihood of frailty, which increases the likelihood of poor health outcomes, which is why we need to be thinking about identifying and addressing geriatric syndromes wherever we can. And obviously, this is even more important in individuals living with dementia. We know that geriatric syndromes, specifically polypharmacy, weight loss, and falls are the ones that I focus on, are important in these individuals because they cause increased morbidity and mortality than they do even in other older adults. So we know that older adults with cognitive impairment have 1 to 2 times greater odds of multiple falls and injurious falls than adults without cognitive impairment. We know that older adults with cognitive impairment have twice as high the rate of BMI, body mass index loss, than even normal older adults or those with cancer or congestive heart failure. And we know, of course, that polypharmacy, which we'll talk more about the definition in a minute, but that independently increases the risk for falls and adverse drug events and hospitalization. So we need to address these geriatric syndromes in all of our patients, especially those living with dementia, because they're clinically important. And if we're not looking for them, we're missing them. And I can speak to this a little bit from chart reviews that we've done in our own local population, and this is certainly reflected in the greater literature as well. We did a chart review a couple of years ago in among the patients who were referred to our Center for the Aging Brain to look and see how many of them had geriatric syndromes. And so we looked at 546 charts of individuals over age 55 seen over a 2-year period, and we included all patients, including those who were not found to have any cognitive impairment at all, as well as those with MCI or dementia. And we found that around 50% of them had unsteady gait or falls, weight loss, and polypharmacy. So we know that they're really prevalent. They're there. And if we're not looking for them, we're missing them among this population of older adults with cognitive concerns. And I made my own graphic here for geriatric syndromes to illustrate a little bit about how I think about it and how I teach about it. And as I mentioned before, the idea that any geriatric syndrome, which you see sort of in the pink circle in the middle, a specific type of functional impairment, a symptom or a syndrome, we might take falls as an example, has multiple different inputs on the left side of the slide, different body systems where there's some kind of deficit for some reason. And then those deficits kind of interact with each other. So if we think about falls often don't happen because there's one specific problem that the individual has. There may be changes or deficits in the visual system, in the vestibular system, in the musculoskeletal system, in the central nervous system control of mobility and balance. And all of those together combine to produce the syndrome of falls. And what's, I think, actually hopeful about this model is that when we think about geriatric syndromes, if we know that there are multiple inputs, we can be creative and think about multiple outputs or interventions to address the geriatric syndrome. It's not necessarily going to be one drug, and often it isn't, or one intervention that's going to mitigate the geriatric syndrome. And that leaves a lot of room for creativity and for trying things and seeing what works for our individual patient. And so when I'm meeting a patient that I'm evaluating at the Center for the Aging Brain, what I think is also really fun about this work, and I teach a lot and I try to get trainees excited, we need more people in geriatric medicine, is this interesting interplay in meeting a new patient and trying to figure out, well, what is the cause of their cognitive concern? Do they have, which kind of bucket does that fall into? Do they have mild cognitive impairment? Do they have dementia? Or do they have really normal cognition with cognitive symptoms? And we have to figure out why. And along with that, which of the geriatric syndromes, as you can see on the right side, do they have that might actually be causing their cognitive symptom? For example, do they have depression, and is that causing their cognitive symptom? Or conversely, if they have dementia and they have weight loss, is the dementia causing the weight loss? And then how can I address that in light of that? So it's just a fun, really engaging process, I think, clinically. And this is a lot of what we do in the clinic. And now this is, as I said before, a lot to do in a comprehensive geriatric assessment. I think it's what we should be doing for any individual that we meet who has a cognitive concern that we're evaluating, but it's a lot. So ideally, we use our village, and we have a village to provide comprehensive geriatric assessment for people living with dementia. And in this diagram here, I think I chose this graphic probably poorly because these sort of down arrows, but it's really not like that. It's more of a circle or intersecting circles, really. But I just wanted to list out here some of the different roles that different members of our team ideally can have in providing comprehensive geriatric assessment. So the MD, PA, or MP may be working on treating reversible contributors, addressing the geriatric syndromes, importantly, tailoring medical management of other medical conditions, and anticipating and managing neuropsychiatric symptoms. And of course, really what we find in our group is that the nurses, the social workers, they do a lot of this too. And there's this overlap and exchange between all the members of a high functioning team so that we really help and support and sometimes duplicate each other. And that duplication can be a good thing for patients. If we're lucky enough to have an RN or an LPN on our team, I think they can have an important role in ongoing screening and assessment for functional changes, ongoing comorbidity management, education about managing blood sugars or blood pressures, and troubleshooting and caregiver education. Pharmacists are hugely valuable as well, of course, and we're going to hear from I think it's Dr. Brandt as our pharmacist later today, who's a lot of what she's going to talk about. I'm going to cover just the scrape the surface of that, but in rational prescribing or appropriate deprescribing for individuals with cognitive concerns. And of course, the social worker having an invaluable role as well in financial planning for long-term care, screening for abuse and neglect, connecting with resources and caregiver support. And this is all borne out in the literature as well. This article by Adi Shafir and colleagues in the Journal of Alzheimer's Disease in 2022, they did some focus groups with patients and caregivers about what the process was like when they received the diagnosis of dementia, what they went through, and what they wish they would have gotten. And really, patients and caregivers also valued the multidisciplinary inputs in this process. And so we're going to come back to our patient's story now, having thought through a little bit of the conceptual underpinnings of the comprehensive geriatric assessment and what we're doing in the clinic, and talk a little bit more about our patient. So I want you to know about her functional status. She's currently dependent for all her instrumental activities of daily living, meaning that she's unable to manage finances, medications, transportation, cooking, or shopping at all for herself. She's dependent on her home attendant and daughter to do all of that. She also requires assistance or complete care for most of her ADLs as well. And that's for multiple different reasons. For bathing and dressing, she has some physical limitations in balance and in vision, as well as cognitive limitations. In terms of transfers, she has balance and vision limitations. In terms of ambulation, she can use her walker, but she needs assistance even using the walker because of vision impairments and just deconditioning. And she's having incontinence episodes of bowel and urine. And then there's other concerns, the frequent neck and shoulder pain, that she can't get to the toilet on her own at night. And she's had multiple near falls she's having some episodes of low blood sugar and weight loss. So a lot going on with this individual. So here's her medication. Someone wanted to know about this. She had been prescribed mirtazapine to help with sleep and appetite because of the weight loss as well and because of the depression, but she didn't like it and now is not taking it. She had been prescribed metformin 850 milligrams twice a day, losartan 25 milligrams daily, aspirin 81 milligrams, polyethylene glycol, and I should just say, just in case, the losartan is a blood pressure medication. The aspirin may be unclear the indication in her, although she has had stroke. The polyethylene glycol, as Miralax, is for constipation, and stool softener, Docusate. And then she had been prescribed glipizide as well, and it was still on her medication list. But looking back in the notes, someone had recommended that she stop it because her diabetes numbers were too low. Her A1C was too low. And so then a little bit more of the chart review over the last 3 months prior to this visit. She actually had been in the ER once because of the left shoulder pain. Her blood pressure had been low in the office sometimes, 113/80. And her diabetes number, her hemoglobin A1C, was 6.8%. We could probably talk about kind of what her goal would be, but certainly not less than 7%, and hers had been lower. And so on this visit, we did a quote unquote brown bag medication review. The patient brought in her medications and we looked through all of them, and we found that she actually had stopped metformin, but was still taking the glipizide. And we tried to understand why that was. Clearly we documented recommending that she stop it. And with some digging, we found out that it was simply that there were still refills in the pharmacy, had refills on file, and they were refilling it, and the patient was taking it. The daughter, with so much going on, hadn't made that connection that she was supposed to have stopped it. And so whatever the pharmacy was filling, she was taking. And I'm sure many of you, clinicians, pharmacists, social workers, even nurses, have run into patients where these kinds of things are happening with their medications. And so a bit about her physical exam as well. On the day that we saw her, she appeared well, but uncomfortable and sad. No acute distress as she was sitting up in the examination chair. She was alert and attentive to the exam and trying to answer some questions, although her verbal output was limited. Her speech was clear, and she was alert, as I said, without fluctuations in alertness or attention. Her conjunctiva were injected, meaning her eyes were sort of red and dry. She had no teeth, and her tongue was slightly dry. Her heart had a regular rate and rhythm. Her lungs were clear. And we noted also that she had some muscle spasm in her trapezius muscle and her paracervical muscles in her neck, left side greater than the right side, with some bony hypertrophy of her left shoulder. She had decreased pulses in her legs and cool toes on both sides without any swelling in her legs. And her gait was slow with her walker, and she actually needed her daughter to hold on to the front of the walker and direct it. And she also required assistance to get out of the chair. So we can pause here too. I would love for you to sort of think about, I think I've answered some of the questions that some of you raised in the chat, but what other questions or what interventions are you thinking you might want to recommend for the patient at this point? You're welcome to chat in. And I'm seeing before someone had asked about native language. Spanish is her native language. A great, important question. And someone asked about specialized equipment for macular degeneration and services. Great question. In-home medication management, someone's recommending. Great. Other thoughts, other questions about her, or other things you'd like to recommend? Was religion a big part of her life? No pain medication. She's not on pain medication for her presumed shoulder arthritis. Does she have arterial problems? One of the things I think is so great about doing this with a little bit of a chat and a back and forth feature is I know I am reminded of how valuable it is to have a team in caring for complex older adults like this, because there are things like religious role in her life that I hadn't thought about, and that, we may not think about until we have another member of our team jump in. And is she well hydrated with that low blood pressure? Yeah, lots to be concerned about. Yeah, with this patient. Okay, and so we're going to dive in now to talk about different geriatric syndromes. And we might identify with this patient as a model, and then how we can address some of these things in our patients. And I'm seeing some other really interesting things in the chat about what her insurance is, caregiver support, and OT home safety assessment. Lots. So we're going to, yeah, great. It's so rich to have such a diverse team. So to think about geriatric syndromes, we want to know which medications are potentially inappropriate for our patient. We're going to talk about polypharmacy first. And I don't think so far in the chat anyone had mentioned medications that, and Dr. Manocha mentions to please change the blue box to everyone so everyone can see the chat. I have that's why I'm reading it out, because I wasn't sure, but I hope I've mentioned many of the different things in the chat. But if I would love for folks to chat in as well now. You saw her medication list, and maybe the pharmacist will jump in here. Which medications do you think might be potentially inappropriate for this patient? Someone identified if she's sad, is she on a depression medication? So maybe that was missing. I don't know if anyone else saw other medications. Metformin may be too high, affecting her appetite. Yeah. See if anyone else identifies other medications that might be inappropriate for her. If her blood pressure is too low, it may need to reduce or discontinue the glipizide. Yeah. And I'm going to move on to not spend too much time here. Someone recommends that she's missing some non-medical treatments, such as a muscle rub. And someone raises the question of whether aspirin's really appropriate. Yeah, and I was waiting for someone to mention the Docusate, the stool softener. Unclear how much that benefits patients. There's really not a lot of literature for that. And so those are some of the things we could think about with her medication treatments, certainly. And she's maybe missing a statin, maybe. There's other things we don't know, certainly not on a depression medication right now. So let's think more broadly about polypharmacy. To zoom out a little bit from this patient, we can define it as more than 5 medications or potentially inappropriate medications. And so both of those definitions exist in the literature. Polypharmacy often comes with difficulty managing medications. It's sort of as a corollary to that. And so it can get pretty messy when people are experiencing polypharmacy in the context of cognitive impairment. One of the tools that I really like for helping to identify polypharmacy, potentially inappropriate medications or too many medications, is this medication screening questionnaire, which was developed by my close colleague, Claudine George, who's a pharmacist and a geriatrician. She likes school. She has a master's in science also. And so she published this in JAGS in 2011. And this medication screening questionnaire is really helpful for systematically going through the medication list to make sure that the medication list is optimized and appropriate for a patient. And so I would recommend considering using a tool like this. And obviously there's the stop and start tools, Beers criteria, many. I like this medication screening questionnaire as well, for at least dedicating one visit for a patient that has cognitive concerns that may have polypharmacy, to really unpacking their medication list and examining it closely. And the other handy, very basic tool that I emphasize when I'm talking with trainees is the basic rule from the Choosing Wisely campaign from AGS is don't prescribe a medication without doing a drug regimen review. And I think it's just a necessary, really critical antidote to some of the other pressures I think that we may experience in clinical care with patients, which are different metrics and guidelines and recommendations about certain medications that are recommended for our patients, about targets for goal-directed medical therapy for different conditions. And yet all too often, we don't really know what a patient is taking or not taking. And then we add something else, and then we see a prescribing cascade. And I know that Dr. Brandt is much more going to speak about all of this much more expertly later, but these are a couple of tools that I like to use and teach. And in terms of managing polypharmacy, obviously utilizing our pharmacists, that's what the star there is for on our team, if we have that benefit. And if we don't, to practice some deprescribing. And again, I'm not an expert in deprescribing, but these are sort of my back of the envelope, you might say, or the basic deprescribing strategies that I use and teach to my trainees. Obviously prioritizing. Sometimes, as many of you noted, multiple different medications may be potentials for deprescribing, but we might want to do it one medication at a time when possible, because sometimes we don't know what a medication is doing until we stop it. And so having some clinical humility there. So prioritizing, doing one at a time, tapering when appropriate. Sometimes we can't just stop something cold turkey, and really having it be a shared decision-making process with the patient. I've met many patients who are somehow attached in some way to one of their medications that I might see that has no specific purpose for them or might even be causing side effects, but they have different reasons that medication is really important to them. And so we have to engage in a shared decision-making process, of course, when we do deprescribing. And in my clinical role, I'm usually working as a consultant. And so I have to triage the deprescribing decisions based on clinical acuity, because I'm meeting the patient that one time. I have, an hour for a visit, so I can do a comprehensive assessment. And I want to defer changes to the primary care provider or the clinical pharmacist when possible, when there are routine changes to make, and really communicate my recommendations directly with the rest of the care team. I only make immediate changes if I've identified something that's really threatening to the patient. And of course, whenever we do make medication changes, it's important that we arrange follow-up, because again, sometimes we don't realize, we're not exactly sure what the impact will be of changing a medication. So these are some strategies for managing polypharmacy. Now we'll move to talking about weight loss. And I wanted to ask and give a chance for people to jump in if you're interested about what might be causing weight loss in our patient. And some people had mentioned that the metformin might be contributing to weight loss in our patient. I wonder if people have any other thoughts, anything else you noticed about this patient that might be causing weight loss. No teeth. I'm so glad that someone picked up on that detail that I included in the, condition of mouth teeth, right? So preaching to the choir in many ways here. Does she have C. diff, right? Which sometimes people can have chronically and long-term. That's, definitely, and depression. So lots of potential causes for her not to want to eat. And then, of course, we would mention she has a home attendant. So hopefully this issue doesn't affect her, but we know that we meet forgetting to eat, right? Exactly. So for many of our patients with cognitive impairment and dementia, as the executive function and apathy, as those symptoms of the dementia progress, people may lack the ability to organize eating. They may have less motivation to do it. And so there's obviously a lot that can contribute to weight loss. When we are assessing nutrition, here are some of I wanted to just check the chat. There's some other great ideas. Who's cooking for her? Does she get Meals on Wheels? Can she see the food because of her visual impairment? Does she need special utensils? Is she getting food she likes? So many great ideas. And so when we assess nutrition, we look for clinical red flags. A low body mass index is associated with increased mortality, we know, in older adults. So under 22 for women and under 23.5 for men. And I would add here, too, that there's really a J-shaped curve. I'm sure many of you are well aware of this, for the relationship between weight and mortality in older adults. So older adults who are underweight have a higher mortality risk. Excuse me. Older adults who are normal weight have less risk than those who are underweight. But the people who do best, the older adults who do best in terms of this correlation, is older adults who are overweight, who are slightly overweight, actually have the lowest mortality risk as associated with their weight. Obesity, then the mortality risk goes up. And so there's this interesting J-shaped curve, which is part of why we're so concerned about weight loss. We look for low BMI. We look for weight loss that's unintentional or significant amounts. So more than 5 pounds or 5% over 1 month, or more than 10 pounds or 10% over 6 months. These are some handy rules of thumb. Or when we see patients that have hypoglycemia, a low blood sugar, hypotension, low blood pressure, presenting with those things, maybe a clue that there's some nutritional issues. And we saw some of that with this patient story that I presented. I like this oldie but goodie. It's a mnemonic from 1995 in the Annals of Internal Medicine, Meals on Wheels, as a helpful way to think about, to remember the multiple potential causes of unintentional weight loss in the older adult. When I teach this, I wouldn't expect any of my trainees to memorize this mnemonic. This is kind of a lot. What I like about this, though, is it reminds us to think really broadly and deeply that there are many possible causes of weight loss in an older adult. And again, as a geriatric syndrome, we have to think about what are all the different possible causes, and can we make multiple interventions to address them? When I think that what sometimes happens for medical trainees is that they see an older adult with persistent weight loss and they think, I have to rule out cancer, which is often important. And unfortunately, Occam's razor, the law of parsimony, doesn't necessarily apply to older adults who may have more than one thing going on. And at the same time, very often, if we only do the CT, the CAT scan of chest, abdomen, pelvis to rule out a cancer, and that's okay, and then we don't look for other causes of weight loss, we're really going to miss it. And I can't say how many patients that I've met at the Center for the Aging Brain who maybe the trainee or the provider didn't really understand why they were losing weight. And so we have to really think broadly and deeply about all the potential causes. And so in terms of managing nutritional issues, I think about sort of 3 buckets of strategies we're going to use. We're going to address the specific causes. So whether it's a medication like metformin that we need to change, we're going to certainly do blood work and address malnutrition while we're at it. So is there low B12? Is there low iron? What's their albumin level? That can sometimes clue us in a little bit. So we're going to do some blood work, and then we're going to involve specialists. Sometimes we need to get ENT or speech and swallow involved when there are swallowing issues. And certainly dental care. And Dr. Varela will go into much more detail about this, and I think mentioned today some of the connection between weight loss and nutrition and oral health. And so we need to address some of the specific underlying causes. Often what we need to do is education. And I know Ms. Gordon, the social worker, is I think going to touch on some of this on education around diet and nutrition to help prevent hospitalizations in older adults with dementia. And what I find is often the education needs to be about liberalizing the diet. Sometimes our older adults make it to this older age having managed their diabetes and high blood pressure for many years, and they're still priding themselves on keeping that low calorie, low fat, low whatever it is diet, and that may be contributing to weight loss. So we may need to liberalize, we may need to increase the meal frequency, add snacks, and then refer. The third bucket is referring out for additional assistance, whether that's getting Meals on Wheels, getting a home attendant, someone in the home. Sometimes there's just no replacement for that. And then certainly creating a social eating environment. In our area, many of the senior centers cater to the different cultural groups that tend to cluster and live around that senior center. And then they provide meals that actually are culture appropriate for those individuals. And that's an important consideration. I know some of you mentioned this in the chat. That's an important consideration for making sure that older adults have access to the food that they want to eat. So we can address nutritional issues with some of these strategies. And then moving to assessing fall risk. We look for clinical red flags in the history or the physical. We know, of course, that any older adult who's cognitively impaired is at increased risk of falls just because of the cognitive impairment, absent any other risk factors. So we have to pay closer attention to that. And then if an individual has a positive screen for increased risk of falls, such as a fall in the past year, feeling unsteady when walking, worrying about falls, or if on physical exam, we make observations that suggest increased risk, like the patient is slow or unsteady walking from the waiting room to the exam room, or if they're not using their gait assist device correctly. And when we're assessing fall risk, in order to help us make those observations, we may use something like the Get Up and Go test. And I anticipate that many of you on the call are familiar with this. Basically just asking your patient to rise from a chair. And of course, I always have to, when I do this, I always say to the patient, in a minute, I'm going to ask you to stand up. But when I do, don't stand up yet, because they always want to try to jump right out. Don't stand up yet. But I want to ask you not to use your hands on the arms of the chair to push up. You could put your hands in your lap or keep them up. I want you to stand without using your hands. And so you're going to ask them to get up, stand, walk as many feet, 10 feet if you have. I often ask someone to do this in the exam room for convenience sake, turn around and walk back to the chair, and I'm making observations there for abnormalities in any of that process. And I also really like the 4-stage balance test to help with making these observations. Sometimes I meet older adults with, let's say, mild cognitive impairment who have never had a fall, and they're not really thinking about falls, and I don't want to give them something to worry about necessarily. And at the same time, maybe they're wearing their high heels and they really want to wear their high heels, or they have some beautiful Persian rugs in their apartment that they are very attached to. And I maybe want to find a point of connection for them to understand fall risk and think about strategies to avoid falls. And so I like the 4-stage balance test because it's a little bit of a stress test for balance. I can help sometimes bring out balance impairments that I might see that the patient might not see. But when I ask them to do this assessment, where they're going to stand in 4 different positions, each one for 10 seconds, and I'm providing contact guard the whole time to make sure they don't fall in my office. When I ask them to do, for example, the semi-tandem or the tandem stance, and they realize, oh, I'm really having trouble, I can't do this unsupported. And of course, if a patient, when you're doing this test, can't last for 10 seconds independently in one of the stances, you shouldn't move on to the next one because of the risk of falls. But when I do this with patients or family members in the room, sometimes that gives me a point to then discuss what are some of the strategies or interventions we might want to implement to reduce the risk of falls, where they might not have thought of themselves previously as someone who has that risk. So this can be very powerful for assessing and managing falls risk. And of course, I want to just mention the steady initiative from the CDC, stopping elderly accidents, deaths, and injuries. This toolkit I really like, and there's all kinds of course, I'm really not a falls expert. That's not my one area, but there's all kinds of tools and strategies and interventions out there. I like the STEADY toolkit. And if you haven't gone to the CDC website and explored this, I would encourage you to. For professionals, it's helpful, and I use this with trainees, to use the STEADY algorithm as a place to remind you about what are the different kinds of strategies or interventions we may want to consider, to what should we look for and what should we intervene on for older adults who are at higher risk of falls. And then there's great patient information available in multiple languages. I like the Check for Safety brochure, which is a kind of a home safety checklist. I would love if all of my patients could get an occupational therapy and physical therapy assessment in the home. And for different reasons, that's not always possible. So if that's not possible, I at least like to provide them with this brochure. And then the brochure for family caregivers, how to protect your loved ones from falling, which touches on multiple different areas. So this is one strategy for managing falls risk. Of course, we have to remember to evaluate medications, knowing that being on more than 4 medications, that in itself increases the risk of falls. And we look for classes of medications that may increase falls risk, and then again have that joint decision-making, shared decision-making conversation about what we might want to change. And then I also wanted to highlight that there have actually been systematic reviews that there's really good evidence for multiple different types of falls risk reduction strategies, whether it's group exercise, Tai Chi, home safety assessment and modification. And I know that one of the other speakers today is going to touch on this more, withdrawing psychotropics. So there's really evidence-based falls risk intervention. There's a lot we can do. And so even though we may not, and vitamin D supplement, someone asks, that's a great question. We can come back to that in the Q&A. There's a lot we can do. And even though we may not prevent falls, and I talk about this a lot with trainees, but it may not be fall prevention, but it's falls risk reduction. There's a lot we can do and that we should be doing in older adults with cognitive impairment and dementia who are at higher risk of falls, no matter what else. And so I'll move in my last few minutes here to talk about operationalizing geriatric syndrome detection and management, to touch on a little bit more about the multidisciplinary team approach, the EMR tools that we use, and skilling up trainees. And just to say the multidisciplinary team approach, so I mentioned this earlier, and I'm going to bring up the same slide about using the village. When I don't practice primary care right now myself, I precept geriatrics fellows, although this is one of the stories in geriatrics that we need to turn around. We don't have enough trainees. We don't have enough medical residents going on to complete a geriatrics fellowship, and we need to turn this around. So we often don't have enough fellows for me to precept, but all that to say, I'm doing mostly consultative care, and having done primary care, I remember what it's like. And I have such, I hopefully compassion for my colleagues in primary care who are trying to do what I can do in an hour and 15 minutes. And the strategy that I talk with trainees about and recommend for that is breaking it down, chunking it out, obviously capitalizing on the interprofessional team if you have access to that. And if not, to break it down into multiple visits. So we're going to address falls in one visit. We're going to address weight loss in another visit, polypharmacy in another visit. And sometimes that's how we have to do it. One of the other strategies for operationalizing is using the electronic medical record to support our efforts. So we, at our system, we have EPIC as our electronic medical record system, and we've developed a template that we use for these visits for comprehensive geriatric assessment of older adults with cognitive concerns. We use some of the, and you can see in the middle of the screen, the tools. I list flow sheets first. The flow sheets in EPIC are kind of an off-the-shelf, out-of-the-box feature that EPIC has for documentation of certain things. So we use the flow sheets for functional status assessment and documentation for falls risk, for nutrition. However, at the bottom of the screen, you can see the last little arrow pointing to the medication review section of this screenshot of this note. We built our own drop-down menu and screening tool for assessing for polypharmacy and potentially inappropriate medications. Some health systems with different builds of Epic may have other tools that are built in. We built our own. There's a lot of opportunity here to utilize the features of the electronic medical record systems to help support our work and make it easier to provide the right care for the right patient and document it well with less burden. I mean, more clicks, which is true. I can't get around that. At the same time, allowing more consistent and complete documentation for all the hard work that we're doing. So we've built an EMR template to help us with this. And the EMR template, this is a sample of an assessment and plan feature of the template, where we created some quick text or smart phrases that then explain the clinical reasoning for how we're thinking about this patient's falls risk, for example, and what recommendations we're going to make. We make sure that our assessment and plan templates include a reference to a clinical guideline or a citation of the literature when possible, because studies have shown that primary care providers really appreciate understanding the basis and the background, the evidence base for where specialist recommendations may come from. And we try to keep it kind of organized and bulleted and yet also thorough. And so our geriatricians or trainees who use these template pieces can edit them however they like, but it provides them a starting place and hopefully makes documentation easier and more complete. And this, I think, is also a way to help us skill up trainees. Again, we need to think about workforce considerations. I'm thinking about that. How do we build geriatrics care into the care of more health professionals, period? And so we have developed a curriculum for this that we use with our geriatrics fellows and with our rotating trainees. Multiple parts of this curriculum. The trainees rotate with us at the Center for the Aging Brain. We've developed the EMR template, and then we have a 6-part training series for the geriatrics fellows and for any newer geriatrics attendings who may have less experience in patients with cognitive impairment, on how to approach the interview, how to make a diagnosis of cognitive impairment, and how to use the template to facilitate comprehensive geriatric assessment. And then we have some really rich monthly case-based conferences with our multidisciplinary team that all of our trainees come to, focusing on the clinical aspects of the comprehensive geriatric assessment and dementia diagnosis, as well as behavioral health and addressing caregiver needs in dementia. And so coming back to wrap up with the patient story that I started with, I wanted to, some of you have in the chat added ideas and strategies to kind of a comprehensive care plan for this patient that I hadn't thought of, which I so appreciate. And I wanted to sort of just to share what we came up with as a comprehensive geriatric care plan for this patient. And I highlight this, I think, my bias, I think, is that I work in a multidisciplinary team where all of us on the team are aware of how important the multidisciplinary approach to individuals with cognitive impairment and dementia is. And yet, if we look more broadly and think about sort of where Alzheimer's or dementia care can sit and how it's thought of, I think that we have more work to do to make sure that the powers that be and health systems and on a societal level, that there's an understanding that dementia care is not in the wheelhouse only, for example, of neurology, that it is a problem of the brain, but that a comprehensive, holistic, systematic approach is needed. And so when we think about a geriatric care plan, it's not going to be Alzheimer's disease, fast stage 6, recommend memantine and caregiver support. There's a lot more to think about. So for this patient, it turns out that the daughter had declined a referral to Care in Kind, which is our local caregiver support organization. The patient declined an antidepressant, but we plan to offer those again at the next visit and to have our social worker contact the daughter to follow up to connect with caregiver support. For her abnormal gait, exacerbated by her blindness and her shoulder pain, making it hard to use her walker, and her high risk of falls, we provided a letter to try to help her get more 8 hours. We'd had a discussion about considering nursing home placement, that it might be the best for this patient, some assistive devices, or referral to physical therapy, and then addressing all the other issues, stopping the metformin and the glipizide. And we called the pharmacy to stop the refills, stopping the stool softener, some exercises and referral to PT for her shoulder pain, heat and massage, around the clock Tylenol, topical gel, a lot of the things that folks mentioned, some continuing the aspirin. So more things, maybe stopping the antihypertensive, connecting with low vision services. Really, it's a comprehensive care plan and following her up in 4 to 6 weeks. So in summary, I recommend that we be alert for geriatric syndromes and older adults with cognitive impairment, that we implement multifactorial interventions, and that we utilize a multidisciplinary team approach when possible. These are my acknowledgments for my Center for the Aging Brain team, and that's my dear grandmother who inspires my work.